So I will go to the next talk again, that is related to the imaging only. It is the anterior segment OCT in the angle closure disease. Look at this continuum of the angle closure disease. You might have seen n number of times the continuum of the primary open angle glaucoma, which Professor Weinreb has suggested. This is the continuum of the angle closure disease which I have made. When we diagnose the patients having angle closure disease, when there is an intermittent attack, or when there is an acute angle closure, or when there is a chronic angle closure glaucoma, and that is at this stage. And all of us knows that the angle closure glaucoma progresses much faster as compared to the primary open angle glaucoma. So as an ophthalmologist, as a glaucomatologist, it's our responsibility to pick up this disease also at little early stage. And how can we do that? We have to get expertise in doing a good gonioscopy. And if you do a good gonioscopy, then you can pick up somewhere here. But with the imaging technology, still you can identify the patient who is at the risk for development of the angle closure disease at pretty early stage, and probably you can take a better care of that particular patient. So that is the importance of the ASOCT. When you do the gonioscopy, yes, you are able to see all the structure if you are very familiar with the gonioscopy. Same structures can be identified by the ASOCT as well. But there is a difference between the ASOCT and the gonioscopy. As I said earlier in my previous talk, again, the gonioscopy is highly subjective. You may say that this angle is closed, I may say that this angle is open. Obviously, when you have developed the expertise, then probably your views and your thinking may match. But otherwise, two people may have a difference of opinion. Number two, the gonioscopy is affected by the light artifact. When there is lots of light in the room, you may have erroneous finding, and you may see the angle structure which are erroneously visible. Otherwise, in the normal condition, which may not be visible, it may be the appositional closure. As against this, the ASOCT is objective test. You don't put any equipment or any instrument over the patient's cornea. Patient is comfortable. There is no influence of the light, the room light over that. So to some extent, I can say that yes, ASOCT has a superiority over the gonioscopy. What are the risk factors for the development of the angle closure glaucoma? All of us knows from our PG teaching that majority of these patients, they have a less anterior chamber depth, they have a less anterior chamber volume, and there are some more risk factors. Most of these patients, they have a thick iris, the iris area is more, and there is an increased lens vault. Again, it's the same thing. What the ASOCT does, it measures the angle opening distance, the AOD, at two different levels. Obviously, you have to identify the scleral spur, which is little difficult task, and you have a tool, you just place it and it would say that what is the AOD. But that is not important. I'm not going to talk about this. It gives about the TISA, the trabecular iris space area, where again there is a scleral spur, and there is an iris surface, and there is a sclera, and there is a trabecular meshwork. It measures the TISA at 500 and 750. Again, I am not going to talk about this because there is lots of discrepancy. If you have not identified the scleral spur well, and if you have not put your tool at proper place, then you will get all this information wrong. And this is the angle recess area, because the small recess up to the ciliary body is left out in the TISA, so that is covered in this. So it is almost same as the TISA, slightly more or bigger than the TISA. But again, we cannot rely on all these values. These tools are available. You just comfortably place over this scleral space, and all what you get is the ready-made values. Again, in my opinion, that is not of significance. You know, we have done in almost every patient suspected to have angle closure glaucoma, but we were not very comfortable with all these values. Look at this, a beautifully depicted picture. It's my own patients. This is the pupil. We have thrown the light on the pupil, the constricted pupil, and this is a little bit of dilated pupil. You can see that this angle is appositionally closed. When the pupil is constricted, this angle becomes open. So that is an important thing, you know. If you putting the gonioscope, probably you may not see that, but with the ASOCT, yes, you can do that. Another important thing that the people have started believing that the iris plays an important factor. There are three things which are important, which you must know in the angle closure disease. Number one, the patients who are prone for the angle closure disease, they have a thicker iris. Number two, when the pupil dilates, the volume of the iris increases. In the normal individual, it does not happen. When the pupil dilated, the iris of the volume obviously will go down. And number three, and the most important thing, is that majority of the patients who are prone for the angle closure disease, they barely have the crypts. Either they don't have the crypt or they barely have the crypts. You know, majority of the angle closure patients, they have a very thick peripheral iris without crypts. So all this can be picked up with this. You can see that this is the appositional closure. The light is thrown over it, and you can see that the angle is open, and you can see that the volume of the iris is more over here as compared to here in the smaller pupil. So these are the features. People are assessing it, whether they are really important. If they are really important, then you can pick up the patients who are at the risk of the angle closure disease, and you can do the peripheral iridotomy, and probably you can prevent the patient in landing into the angle closure disease. Again, this is this patients, the constricted pupil after the PI. You can see lots of debris, the pigments in the entry chamber, and this, so the volume is slightly increased and the angle has opened. This is the lens vault. You can see that this is the horizontal line, and above this is the lens vault, and in this patient, the lens is removed, and you can see that the volume of the AC is significantly. It's like an open angle. It's the same patient. It's like an open angle. Again, the AC volume. You can see over here that the iridotomy was done. The AC volume has increased. The lens is removed. It's a significantly high AC volume. So again, it indicates that following the lens removal, or even when you do the iridotomy, like in these patients, the iridotomy was done, and you can see that the AC volume has significantly increased. So the AC volume increases, and these patients start behaving like the open angle glaucoma. It's the same. The lens is removed. You can pick up the iris cyst by this. Otherwise, with the gonioscope, it's difficult to pick up the iris cyst. The malignant glaucoma, you can see that the forward rotation of the ciliary body, you know, sometimes you can pick up the ciliary body as well by the ASOCT. It's difficult. The UBM is very helpful, but even we can do that. You can see the rudimentary iris processes in the patient with the aniridia. And if this patient has a Peters anomaly, and you can assess the anterior chamber, what is the status of the anterior chamber, which otherwise clinically you cannot do. This patient was referred to me as a malignant glaucoma from a very far distant after the trabeculectomy, and even initially I thought that yes, this patient has a malignant glaucoma, but when I did the ASOCT, I could see the crystalline lens, and this was just a pupillary membrane. I removed the pupillary membrane, so from just perception of light, this patient has improved to 618, though this lady has a significant cataract, but still, before removal of the cataract, she improved to 618 just by cutting the pupillary membrane. So, the anterior segment OCD has its own importance in angle closure disease. The technology is evolving. Maybe in future, it might be very helpful to us. Thank you very much for your patience.